practice medicine before I came to the US. And when I came, it was just me, Ramiro, and another guy. And now the office is obviously changed significantly, and you guys are pretty much running the show, so which I think is pretty useful because you're going to be doing that fairly soon when you start your rotations. Do you guys have any particular career interest? Are you considering doing a fellowship or residency in some specific field, or you guys know already, or you're thinking?
I'm trying to stay open-minded. I kind of like I am, and
okay.
I see you critical care.
Good. So it's going to be useful for you. What about yourself?
I don't know. I change my mind every rotation.
Happened to me. I thought I was going to be a pediatrician, and then I met parents, and I decided that that was not for me. Although I love kids, but that's not for me. And then, how about yourself?
I've been thinking surgery.
Great, excellent. If you're skilled, I knew from the beginning that I didn't have the skills. You know how you know for a fact that if you're clumsy, you're not going to go anywhere with a surgical career. So I knew for a fact. So I'll tell you. Right now, I'm a nephrologist. I practice at Kaiser, Panorama City, and I spent some time in academics. I was one of the attendings at the UCLA program at the Olive View, and that's why I come to teach you guys, because I still have a great interest in medical education. I also volunteer at the VA Sepulveda nephrology clinic, so I meet with nephrology fellows from the UCLA in Cedars-Sinai program, and I also teach home dialysis to the Olive View fellows. They come to my clinic. I'm the medical director for the dialysis unit San Fernando, the Fresenius San Fernando dialysis unit. So I get students and residents coming to my clinic when they want to rotate and learn about dialysis. So lately we've been doing a lot of internal medicine, and the focus is mostly for board review, because you guys are you guys already taking the CS or the clinical knowledge? You're done with the CS, the CK? All of you? End of this month? Okay, this is going to be very useful. And then then the CS is later, right?
Well, mainly all of us are PO, so we take the PE, but it's similar.
It's similar, right? Yeah, it's pretty much the same content. And yeah, anyway, so like I was just telling you guys, I was here for a long time, and it really helped me out because Dr. Ben-Zur helped me with the letters of recommendation. I was just telling James that he's going through this process, that he really made a difference in my interviewing skills. If you guys need help with that, we're happy to help. Dr. Ben-Zur will be very happy to write you a very strong letter of recommendation. And a little disclosure, he helped me become the first foreign medical graduate that was ever accepted in the UCLA program. And I'm forever grateful, and that's why I keep coming. And I feel like this is home for me, and I'm very close to to Ramiro and the rest of the office staff. So whatever I can help you guys, that's what I'm here for. Okay. So the way I think the easier way to review rheumatology is not by doing content review. It's very boring. Rheumatology is one of those fields in medicine that is very abstract. When people ask me why did I choose nephrology, for me it was a circumstantial thing, but like after I ended up accepting, I was offered the position when I was an intern. They told me if I wanted to be the nephrology fellow in 3 years. I said yes, because I loved the place where I was working, and my wife was doing a doctorate. So at that point I took it, but then I realized, like, man, I signed up for a field that is very tangible, is very objective. Nephrology is very objective, it's numbers, and we see the interventions that we implement are very real time, and whereas rheumatology, I always felt like you gotta really believe whatever they're telling you, because there's really no way of like looking at the prescriptions that we do or the medications that we manage in rheumatology. For your boards, what's important to know is disease associations and disease patterns. So I'm gonna try to do like a question vignette, clinical vignettes, like the same thing that you're gonna get on your boards, and we're gonna take the time to review each of the items, so you know why this is the correct answer and why this one is not the correct answer. So I'm gonna ask for help. I'm gonna ask you to start reading the first question, please.
Sure. A 56-year-old woman is evaluated for a 6-week history
Oops, I'm sorry.
arthralgias.
I'm sorry. What did I do here?
Greater than an hour involving the hands and feet, and severe fatigue.
Okay, so let's stop there. So in rheumatology, when you're getting your boards, you need to pay attention to the timing. because a lot of these questions, the duration of the symptoms is very important to make diagnosis. And the American College of Rheumatology have very strict time criteria to make diagnosis of rheumatologic diseases. So we said that this person is having at least 6 weeks of arthritis, right?
Mm-hmm.
Okay, go ahead.
She has a history of hypothyroidism, well controlled with levothyroxine. She takes ibuprofen, which has not helped to relieve her joint pain. Her mom has osteoarthritis of the knees. On physical exam, temperature is 98.2, BP is 135/78, pulse is 90, respiration is 16, BMI is 32. Cardiopulmonary exam is normal. There is no rash. MSK exam reveals tenderness and swelling of the second and third metacarpophalangeal joints bilaterally. The elbows are stiff but have a full range of motion and are without synovitis. There is squeezed tenderness of the metatarsophalangeal joints bilaterally. CBC is normal, rheumatoid factor is negative, TSH is 1.8, anti-citrulline peptide is positive, IgG antibody against parvo is positive, IgM antibody against parvo is negative.
Okay. So IgG tells you about chronic exposure. IgM is more like acute. So which of the following is the most likely diagnosis for this patient? Rheumatoid arthritis. So, what are the criteria for rheumatoid arthritis? So let's try to review the diagnostic criteria. So, the stiffness we described is classic in rheumatoid arthritis. In fact, I think most patients invariably they do complain of this complaint. My wife has rheumatoid arthritis. Actually, I diagnosed her when we were dating, and I know how hard it is for her. Like the mornings are really hard when she's flaring. You know, like nowadays we have like so many therapeutic available options that, you know, fortunately we can put this disease in remission. But typically on your boards they're gonna give you a very distinct description of synovitis. I mean, they're not gonna tell you synovitis, but look at the way I describe it here. It's basically tenderness and swelling of the second and the third metacarpophalangeal joints bilaterally. So one of the hallmarks of rheumatoid arthritis is a bilateral disease, and typically you see synovitis. They're gonna show you an X-ray, and one of the hallmarks of rheumatoid arthritis is erosive arthritis. So remember, lupus, it also causes synovitis, but on the X-ray, lupus is non-erosive, whereas rheumatoid arthritis is very, very classically erosive. So the time criteria is no less than it needs to be at least 6 weeks, because a lot of the other diseases that I mentioned here, like for instance the parvovirus B19 and sometimes hepatitis A and hepatitis B can actually present with similar presentation, like a symmetrical synovitis of bilateral hands. These diseases are usually resolved by 6 weeks. So if you were to get into detail, if you want to be very thorough, like if a person is just presenting with 6 weeks, those are one of the tests that you can send. You can send a hepatitis B surface antigen and a hepatitis C antibody, and along with the rheumatoid arthritis markers. So patients can have rheumatoid nodules, but they're not very commonly seen. I would say probably 20 or 30% of the patients can have that, and the erosive synovitis that I just mentioned. The CCP was not available when I was in med school. It became available about 18 years ago, I would say. And it's very specific for rheumatoid arthritis. And that's the test. If you see a positive CCP, it's almost always rheumatoid arthritis. Can you have rheumatoid factor negative rheumatoid arthritis? The answer is yes. So that's why if you see CCP and if it's positive, you know what you're dealing with. Okay, and the American College of Rheumatology says that you need at least 4 or more of these criteria for the diagnosis. I'm gonna give you guys the PowerPoint, so if you guys wanna just, to make it easier on taking the notes. But so anyway, rheumatoid arthritis. So the peak age of onset is in the mid-50s, but you can see very early presentation and very late presentation. It can affect anybody at any given point in life, women more than male. But after 60s, you also see males getting equally involved. The diagnosis, like I say, is a chronic inflammatory polyarthropathy. On your boards, everybody knows that they're mostly wrist MCPs, PIPs, and MTPs. However, on your boards, they're probably gonna ask you for like other places of involvement. And one of the board favorites is when they actually the cervical spine joints. No, it's gone. Okay. So patients eventually, when you don't treat them, and this is one of the reasons why we treat them, they develop loss of normal range of motion. And the picture is showing the classic deformities of late-stage rheumatoid arthritis. You know, the boutonniere deformity of the thumbs, the ulnar deviation of the MCPs, and the swan neck deformity of the fingers. Morning stiffness is hallmark, like I said, and patients can also present with systemic symptoms. Rheumatoid arthritis is not a benign disease. Actually, you guys have to always think about rheumatoid arthritis as a systemic inflammatory process that is associated with like end organ damage. And you guys know what happens with rheumatoid arthritis. How do they get in trouble? What are the two major kind of like serious complications or systemic diseases associated with rheumatoid arthritis? You guys know? So one is actually coronary artery disease. Like these patients, in many, is an independent risk factor for having coronary disease. If you go to the online risk calculators, actually it asks you if patient has rheumatoid arthritis. And the second thing that is actually serious is the development of malignancies, because like a lot of the lymphocyte T pathways are defective in patients with rheumatoid arthritis. So these patients are more prone to develop non-Hodgkin's lymphoma at one point in life. The labs, we know that the rheumatoid factor detects the IgM that reacts to the Fc portion of the IgG. Which other molecule is very similar to rheumatoid factor? You guys remember which other? And you can actually have a false positive.
Anti-nuclear?
No, not the anti-nuclear. The cryoglobulin. Cryoglobulin. So if you have a patient with Hep C and they give you like a classic vasculitis, I have a Hep C case here. Who's calling me? They actually resemble the same, like the Fc portion of the IgG can be a false positive, and the CCP is a lot more specific. These patients have elevated ESR and CRP. They may or may not have leukocytosis, thrombocytosis. In the imaging, look at the erosion that I put in the picture. They have like significant erosion. Remember, lupus is non-erosive. If they describe synovitis and you don't see any erosions, and on your boards, the nice thing about the boards is like they're very clear cut. They don't give you like a little bit of erosion. They give you an erosion like this. So that way they don't confuse you and then they make it easy. But you can do like an MRI and ultrasound. Is more sensitive imaging when you suspect early erosive disease, but it's a lot more expensive and we don't always do it. Okay. So why don't you help me with the second question, please?
Okay, a 76-year-old man comes in for a preoperative evaluation before total joint arthroplasty of the right knee. He has a 24-year history of rheumatoid arthritis. His disease has been stable, but he has had progressive pain and loss of range of motion of the right knee. He has no other medical problems. Medications are methotrexate, a folic acid supplement, and prednisone. On the physical exam, temperature is 37.2 degrees Celsius, blood pressure is 136/80, pulse rate is 90 per minute, and respiration is 18 per minute. BMI is 23. Cardiopulmonary exam is normal. There is mild tenderness of the MCP joints bilaterally. He also has bilateral ulnar deviation and swan neck deformities involving the third digit of the right hand and the fourth digit of the left hand. Extension of the cervical spine is painful and decreased. There is a bony deformity of the right knee. Extension of the right knee is decreased by 10 degrees and flexion is limited to 110 degrees. Neural exam is unremarkable. Laboratory studies are normal, including complete blood count and serum creatinine level. Chest radiograph and ECG are normal.
So which of the following preoperative diagnostic studies should be performed? So they're giving you a very classic description of a patient with rheumatoid arthritis, with rheumatoid arthritis features. He's 76 and he's undergoing pre-op evaluation for a total knee arthroplasty. So this patient is going to be undergoing general anesthesia, and they're asking you, based on the history that I gave you, which pre-op test is critical in this patient? And the reason being? Right, and it is actually real medicine, like sometimes the patients, like I have a patient that's getting a kidney transplant, And UCLA specifically requested that the anesthesiologist sees the patient because she has a history of severe rheumatoid arthritis. And the consequences when they intubate the patients, actually it can be cervical instability and the atlantoaxial articulation luxation, and patients can actually die. So that's why X-ray eval preoperatively. So on your boards they may ask you like this kind of involvement because everybody knows about the MCPs, like I said. So the extra-articular manifestation of arthritis, you can get ocular manifestations, either scleritis, episcleritis, peripheral ulcerative scleritis, like a puck. That's how ophthalmologists call it. But you can also get the subcutaneous nodules. My mother-in-law has them. My wife has rheumatoid arthritis. Her mother-in-law my mother-in-law also has it, and she did develop the subcutaneous nodules. One of the coexisting features of rheumatoid arthritis can be Sjogren syndrome. So you guys know about Sjogren's, and I have a clinical case later. Secondary Sjogren's. Patients can actually have lung disease. That's one of the rare complications of rheumatoid arthritis, which is basically non-specific interstitial pneumonia. They can develop Felty syndrome, which is the granulocytopenia, splenomegaly, and the rheumatoid arthritis. I've seen only one case in my career. It was a young female. And if you guys ever see a mononeuritis multiplex, we all know what that is. You guys know what that means? Mononeuritis multiplex. So the way they put it on the board is somebody who develops some sort of like a drop foot or some sort of radial nerve, like a single neurological lesion, like either a median nerve involvement or radial nerve involvement or ulnar involvement. Every time you see that on your boards, you have to think about a small vessel vasculitis, or you have to think about some sort of rheumatologic condition, always. And this is going to be on your board, guaranteed. So it's called mononeuritis multiplex. They're not going to tell you mononeuritis multiplex. They're just going to give you a clinical case, like somebody with a single nerve involvement. They're also going to try to trick you to answer like RDS, like reflex sympathetic dystrophy. But remember, those patients, they usually have a history of trauma and they usually have like a lot of severe pain. Whereas the patient with mononeuritis multiplex, they just present with like neurological claudication of a single nerve group or a single nerve. Okay, and that when you see that, you think about vasculitis, particularly small vessel vasculitis. And like I said, the coronary artery disease is the leading cause of death in rheumatoid arthritis patients. One thing I didn't put here is that patients with rheumatoid arthritis can develop renal amyloidosis. Like every time you have like chronic inflammation, you can develop renal amyloidosis. Any inflammatory process, like a patient with like osteomyelitis, chronic osteomyelitis that is not treated, they can end up developing a lot of proteinuria, nephrotic syndrome related to renal amyloidosis. Okay, so can you please help me with the third one?
A 55-year-old woman is evaluated for a 3-month history of fatigue, morning stiffness lasting for 1 hour, and decreased grip strength. She drinks 2 glasses of wine daily and is unwilling to stop. Her only medications over the counter are ibuprofen 400 milligrams 3 times a day, which has helped to relieve her joint stiffness. On physical exam, vitals are normal. MSK exam reveals swelling of the MCP and PIP joints of the hands and decreased grip strength. There are effusions on both knees. The remainder of the PE is normal. Labs, ESR 35, CRP normal, Rheumatoid factor positive, ANA positive, anti-CCP positive, ALT 25, AST 28. Radiographs of the hand show soft tissue swelling, but no erosions or joint stationary. Radiographs of the feet are normal. Which of the following is the most appropriate treatment for this patient?
Okay, so we all agree this person has what disease? Right, rheumatoid arthritis, right? So this question is geared more like towards management. So the American College of Rheumatology like favors the use of methotrexate on everyone except 3 patients, which are 3 groups of patients, which are, you guys remember, absolute contraindications for methotrexate use?
Lung disease?
No.
Kidney disease?
Kidney disease, advanced kidney disease. It's very difficult to follow levels and you can OD these patients. It's actually be very serious.
Pregnancy?
Pregnancy, obviously, yeah, absolute pregnancy. Liver disease is liver metabolized, and patients that are actively drinking alcohol. That's why I put it in red. So you see that, like unwilling to stop drinking alcohol, you can use methotrexate. So the most common, actually the Plaquenil, I'm sorry. I already gave you the third one, damn it. Sorry. So you're lucky. So Plaquenil. You guys know about Plaquenil. Plaquenil is a very old medication that was initially developed as an anti-malarial medication. It was one of the first DMARDS that came out of the market. When I was in med school, you guys are living a beautiful age in medicine when we have biologics and we have like a lot of like new things. When I was in med school, we used to treat rheumatoid arthritis with penicillamine, gold, and sulfasalazine, and hydrochloroquine was actually the latest, like the new kid in the block when I was in med school. But nowadays we have like so many different things, like including rituximab and some of these IL-1 inhibitors and TNF alpha blockers. We're going to cover some of these things later. But anyway, so hydrochloroquine is a safe medication. It's effective in controlling patients with joint complaints, but it's not very effective if the patients are very inflamed. So like I told you, the ESR is mildly elevated and the CRP is normal. So if your patient is very inflamed, you need to use steroids and you need to use something stronger. But both in lupus and rheumatoid arthritis, Plaquenil is very effective controlling these symptoms. One of the nice things about Plaquenil is it can be used in pregnancy. So my wife actually took it. We just had a baby. My wife took it throughout the whole pregnancy because she was flaring really bad. Supposedly these rheumatologic diseases get better with pregnancy, but that wasn't the case for her. And another important thing that you guys need to know about Plaquenil is that if you're prescribing it, you need to refer the patients for a retinal examination once a year. So if you don't do that, you can actually cause severe uveitis and deposition of Plaquenil in the uvea layer, and you gotta always refer these patients for a yearly retinal exam. Okay, so methotrexate we can use on this person. Enbrel, it's probably too much for her. Like I said, she's not inflamed, so it's more like not necessary. And increased ibuprofen, you know, that's not going to help much, and you're probably going to end up having like toxicity related to NSAIDs. We're going to talk about NSAIDs toxicity later. Okay, go ahead.
A 33-year-old woman is evaluated during a follow-up visit. She was diagnosed with rheumatoid arthritis 3 months ago. At that time, she began methotrexate therapy and a folic acid supplement. She also takes ibuprofen and acetaminophen. During this treatment, she still has 2 to 3 hours of morning stiffness daily and wakes frequently during the night with pain and stiffness. She also has persistent pain in the hands and feet. On physical exam, vital signs are normal. The neck and shoulders are stiff but have full range of motion. Small nodules are present on the elbows. The right elbow has a small effusion and has 15 degrees of flexion contracture. The wrists and MCP joints are tender bilaterally, and there is synovitis of the wrists. The left knee has a small effusion. The MRP joints are also tender bilaterally. Hemoglobin 12.2, platelets 460, ESR 45. Radiographs of the hands show periarticular osteopenia and erosions of the right ulnar styloid and the base of the left fifth metacarpal bone. Which of the following is the most appropriate next step in the patient's treatment?
So we're going to add the TNF alpha because they gave us a history of erosions that is not sufficiently controlled with monotherapy with methotrexate. These medications work better in addition to methotrexate. So it's not like you're going to stop one and you're going to add the other. And that's the reason why number 4 is not correct. So, you know, and the cyclophosphamide has no role in the management of rheumatoid arthritis. You guys know why we use cyclophosphamide? You guys remember Cytoxan? In which rheumatologic diseases we use it? So we're gonna review that later, but primarily in lupus, also in ANCA-associated vasculitis, and cyclophosphamide is part of like a lot of the different regimens for lymphomas. In rheumatology and nephrology, we use a lot less of a dose. Typically, we use 0.5 grams per body surface area. There's so much cyclophosphamide that you can prescribe in your lifetime. In other words, the cumulative risk exponentially goes up if you exceed anywhere from 30 to 35 grams in your lifetime. So that's why you have to be conscientious about prescribing this medicine, and there's a start date and there is always a stop date. I used to have an attending that used to tell me that there's nothing more dangerous than a negligent rheumatologist, and I completely agree with him, because rheumatologists can really hurt people when they're not cautious about prescribing these medications and actually having a goal, like a mutual goal. If for whatever reason you guys end up having, or you or your loved ones have a rheumatology condition, make sure that you always discuss starting date and end date, because you cannot be on these medications forever. You're going to end up having like serious complications. Cyclophosphamide is associated with cystitis, and it's also associated with bladder transitional cell carcinoma, and that's one of the reasons why we use a medicine called Mesna before and after the infusion to diminish the risk of bladder toxicity. And another thing that's notorious about cyclophosphamide, it can cause infertility, both males and females. Females are more prone. There are some protocols in place to minimize the risk of infertility by putting the ovaries to sleep. Usually they give them Lupron or any of the progesterone-based injectables to try to put the ovaries to sleep. But you may want to, if you're going to treat a young female with this, you may want to consider the options. If money is not an issue, they may want to consider like harvesting or doing one of the techniques to avoid infertility. But it's a great medication in terms of response for lupus and response for vasculitis. It's been in the market for 40 years probably, and a lot of the trials were done in the 1980s by the NIH, and the safety profile and the response record is being well documented. So when they bring these new drugs, sometimes the way I see medicine is like I want to make sure that I use a medication that I'm very comfortable and I know the side effects, versus like using a brand new medication that we don't know the side effects. A lot of the times, like when rituximab came, people were using it for everything, and now they realize like the risk of developing lymphoma 10 years out is pretty high, and we're seeing a lot of people coming out with lymphoma. But again, like there's not such a thing as a medication in rheumatology that is not full of side effects. So always remember that. But the benefit is always greater than the risk. That's the reason why we end up treating these rheumatology conditions. And remember, for your boards, rheumatoid arthritis patients, they die from coronary disease. Always remember that. Okay? So discontinue methotrexate because of vasopressin. Okay, very good. So previously we thought about this, a step-up approach. So we started with NSAIDs and steroids, then we added a DMARD, and we no longer use that. The RA disability is dramatically reduced when you diagnose the patients early and you avoid any type of permanent joint damage. And that's the reason is when you develop you start treating the patients with DMARD right away. Like when I met my wife, actually I diagnosed her when we were dating. She told me no, my doctor's giving me ibuprofen and she's telling me that I have a little bit of arthritis. Like, what do you mean a little bit of arthritis? I don't understand what she's telling you. She clearly has synovitis. And she's like, yeah, she said I have a little bit of arthritis. Yeah, but does she have a last name for the arthritis, number one? And number two, there's not such a thing as a little bit of arthritis. If you have rheumatoid arthritis, you have to treat it. And you have to explain that to the patients, because some doctors, are like my wife's doctor, you have a little bit of arthritis, there's not such a thing. You can be left with permanent joint damage if you leave the inflammation for months. Okay, so the DMARDs, we have the non-biologics. So we talk about the Plaquenil. I already told you guys, you have to send the patients for annual eye exam, and it is safe to use in pregnancy. So we have methotrexate, which is the drug of choice. Methotrexate is a weekly medication. Typically we prescribe anywhere from 5 to 7.5. I think the maximum dose is 10 milligrams weekly. You guys know the side effects from methotrexate? You guys remember some of them? Folic acid deficiency. Sometimes the patients can actually have severe stomatitis. That's one of the serious side effects, but it's not serious, but it's extremely uncomfortable for the patients, because imagine you can't even eat for weeks, because that takes 2 or 3 weeks to get better. Immune suppression, leukopenia. if you actually have renal impairment, you can develop like altered mental status and neurotoxicity. Methotrexate, you're always prescribed with folic acid. You tell the patients not to take it on the day that they're using the methotrexate, and sometimes some doctors prescribe it with folinic acid, which is a more like stronger concentrated folate formulation. It's a medication that is very effective, and most patients with rheumatoid arthritis, they respond. The problem is that some of them, they start complaining of side effects, and one of the side effects is hair loss. So you can imagine a female coming to you asking you like to switch because they're having hair loss, and that's exactly what happened to Vivian. When she started using it, she started losing her hair and she got very annoyed by it. Okay, sulfasalazine is a great medication. It's very, very old. It's usually great for primarily for patients that are actually having GI, like one of those IBD, like inflammatory bowel disease with extra-articular manifestations. It works very well, but it's also an alternative when patients fail methotrexate. The bad thing about sulfasalazine is that the dose is pretty high. So, methotrexate is convenient. You use it once a week. Sulfasalazine, you have to use it like sometimes 2 or 3 pills 3 times a day. So most patients, remember we talk about hypertension, you want to find regimens that are simple. Same thing with sulfasalazine, you start giving the women all these pills and compliance become an issue at one point. And then we have biologics, which are basically the new generation in the last 10 years. We have the TNF-alpha blockade, we have Humira, we have Enbrel. I don't know can you guys look up the adalimumab? What's the brand name for that one? Can't remember. But anyway, so and then more recently we have a new class that was FDA approved as of two years ago, I believe, the IL-1 receptor antagonist, the anakinra. I've never used it. I've seen some of my patients coming into my clinic using it, and supposedly that works beautifully. We were reviewing yesterday about lipids, and these new biologics is just incredible, like what we were able to accomplish. And less commonly used, we have rituximab. Again, a lot of the rheumatologists were using it, but it's falling into favor because now we have like the TNF-alpha blockers, and the beta-lacept, and the leflunomide. Leflunomide works pretty well, but one of the risks is that it can cause hepatotoxicity. When I was in training, actually, we admitted a woman who was getting leflunomide for rheumatoid arthritis, and the patient actually ended up she was on a statin for hyperlipidemia, and I think the last thing they did is that she went to the primary care clinic, and they gave her one of the cytochrome P450 inhibitors. I think she got diltiazem, and the lady was admitted with fulminant liver failure and she died. So leflunomide, it's falling into favor because of the risk of hepatotoxicity, but still is an alternative option for those patients suffering from severe. So we have the non-biologic DMARDS. Like I said, the Plaquenil is for milder disease. If you have erosion, if you have a lot of inflammation, we don't use it. And the retinopathy is a risk. The sulfasalazine is also for milder disease, and it's basically a safer side effect profile, and it can cause nausea, vomiting, diarrhea, and in males it can also cause like decreased sperm count, but it's reversible. And methotrexate, remember, you use concurrently with American College of Rheumatology, recommend that we prescribe it for all those patients that can tolerate it. It's always first line. And the mainstay is renal or liver disease, and consistent alcohol use is contraindication, and you're going to look out for bone marrow suppression and pneumonitis. You were mentioning lung, right? Mm-hmm. Yeah, but lung disease is not a contraindication. It's just like pneumonitis is one of the serious side effects from methotrexate. Okay. So biologics, like I said, they're most beneficial when we combine it with methotrexate. And what do you need to do when you're going to prescribe a biologic, by the way? You guys remember? PPD. It's a PPD. It's a must. You have to. And if the PPD is positive, you need to send the quantiferin gold. Like some doctors, they just go straight to the quantiferin gold because it's just easier to do that. And remember that the TNF drugs can also cause drug-induced lupus. What are the other medications for your boards that can cause drug-induced lupus? You guys remember? What else? I'm sorry? Brokinamide and isoniazid. And the TNF alpha blockers as well. Okay? Very good. Why don't you help me with the next one? I'm not gonna make a mistake again. I promise.
A 23-year-old man is evaluated in the emergency department for a 5-day history of headache, blurred vision, and right eye pain. His eye pain increases when he attempts to read or when exposed to light. He also has a 3-year history of back stiffness that is worse in the morning and tends to improve as he becomes more active.
Let's stop there. So for the boards, male with back stiffness, you think about,
Okay.
I'm sorry? Which one?
I was going to say writers.
Writers or what else? Yeah. Okay. Always like, that should ring the bell somewhere. Okay, keep going.
Okay, he does not have arthritis or rash. He takes no medications and is monogamous, so that would rule out.
Yeah, he's monogamous, so I'm actually like trying to exclude the writers.
Right.
I don't think we call it writers anymore, right? I think he was a Nazi. The Dr. Ryder was a Nazi. I think they don't call it like that anymore. I forget how they call it, like reactive arthritis, I think. Yeah. Mm-hmm. Okay.
Physical examination temp is 36.8, blood pressure is 130/76, pulse is 85, respirations are 14. There are no skin lesions, and the appearance of the right eye is shown. Photophobia is present during the pen-light examination of the pupil. Blood pupils react to light. An emergency referral is made to an ophthalmologist.
Okay, so let's stop here. You guys are probably gonna end up moonlighting in the urgent care. I still moonlight a lot. I do a lot of moonlighting in the urgent care. I don't want to lose my moonlighting skills, and when I need the extra money, I just do it easy money. Like urgent care moonlighting is the easiest thing in the world. There are few things that can get you in trouble in the urgent care, like missing an acute eye, like a red eye. Like all the doctors are always treating that. Oh, you're gonna treat this. They just like you have a pink eye. Let me give you this antibiotic, or let me give you this like whatever, antihistamine. So if you have the triad of photophobia, eye pain, and red eye, you have to refer. You have to refer to ophthalmology. You have to call if there's an available ophthalmologist. Probably you're moonlighting in a system where they have an available ophthalmologist, but because the risk of uveitis or iritis and these serious diseases, and some of them can actually be rheumatologic diseases, systemic diseases. So I'm just making a pause there so you guys remember that when you're moonlighting. Photophobia, eye pain, and red eye. So those are the three things that you look in the urgent care. Okay, go ahead.
Following resolution of the eye problem, this patient should be evaluated for which of the following.
So we all agree? Number one, right? Okay. So, let's read the next one because I'm gonna cover on that disease in a minute. Let's read the next question.
24-year-old woman is evaluated for a 2-week history of persistent pain and swelling in the right foot and knee and the left heel. 1 month ago, she developed an episode of conjunctivitis that resolved spontaneously. She also had an episode of severe diarrhea 2 months ago while traveling to Central America that was successfully treated with 3-day course of ciprofloxacin and localized. She has not had other infections.
Why did I give you this history of diarrhea?
It's known to cause Campylobacter.
Right. Mm-hmm. And Campylobacter can cause like severe arthritis. Yeah. That's the same organism that I think resembles appendicitis in children, or yeah. Okay. Go ahead.
She has not had any other infections of GI or GU tract, rash, or oral ulcerations. Her weight has been stable, and she has not had abdominal pain, blood in the stool, or changes in her bowel habits. She has had only one sexual partner 6 years ago. She otherwise feels well. Has no other medical problem. Takes no meds other than acetaminophen for joint pain. Physical vital signs include temperature, normal continuous exam, including the nails, normal, close to normal. There's nothing conjunctivitis or iritis. Musculoskeletal exam was found 1 and 10 minutes to the right knee and ankle. There's some minutes to palpation at the insertion site of the left Achilles tendon. Which the following is most likely diagnosis.
Which one? Enteropathic. Any other takers? Reactive arthritis. Any other takers? It's a long question. This is a reality. On your boards, you have to be able to concentrate and resolve this in 60 seconds. I think that's what you get. And the questions are not short. I don't recall like having short questions. They're very long.
So different spot.
Okay, reactive arthritis. I'm going to talk to you guys in a second about that. So there's a big chapter in rheumatology called the Seronegative Spondyloarthropathies. There is usually a genetic predisposition. I think they're HLA B27 if I'm not mistaken. And some of these patients, they have an infectious trigger. And then there is, when you see this description of enthesitis, like I have a picture on the right bottom, if you see enthesitis, you think about inflammation at the attachment side of the tendon or bone, you think about the seronegative. So whenever they give you enthesitis, enthesopathy, think about the seronegatives. And there is some of these patients can have extra-articular involvement. So if they give you a picture of the bamboo spine, we already covered that, but if they give you a male, you already guys know what to answer. So I got the 4 here, more commonly seronegative spondyloarthropathies. On the left, we have the ankylosis and spondylitis. Patients typically, they describe that the pain gets better with exercise. They may give you that on your boards, the bamboo spine that I just showed you. This patient they have a sacroiliitis, and that's one of the tests that you actually do in clinic. When you suspect it, you can actually do an x-ray. And remember, when you order an x-ray, you always have to write an indication, and you need to orient the radiologist. What is your question? So you need to rule out sacroiliitis. But these patients can also present with extra-articular involvement. Like the case that we reviewed, they had uveitis. They can have restrictive lung disease. That's one of the ominous complications of this disease. They can have like pulmonary fibrosis. Like if they get like pulmonary fibrosis of the apices of the lungs, that's actually like almost pathognomonic of AS. I usually say AS and I think aortic stenosis, but we're talking about rheumatology. So the treatment is DMARDS and biologics. With biologics, the course of this disease really changed. Before, it was really difficult to treat, and the patients had like severe incapacitating joint deformities and high mortality. But now that we have this group of medicines, things have significantly changed. So the reactive arthritis, like we don't call it writers anymore. So basically, it's an acute non-purulent seronegative with preceding infection. When the reactive arthritis affects the spine and the SI joints, we call it reactive spondyloarthropathy. Usually it's an asymmetric arthritis. This is the triad of the writers, is the urethritis, conjunctivitis, and asymmetric arthritis. Any of the organisms involved are the chlamydia, uroplasma, salmonella, shigella, yersinia, klebsiella, campylobacter, and C. diff. And the treatment is NSAIDs, and you treat the infection. That's basically, you don't need to be on a chronic immunosuppressive or immunomodulators. It's just treat the infection and give them NSAIDs. I'm sorry, so the enteropathic arthropathy, so usually peripheral joint involvements, and it flares with the disease. In other words, typically the patients have the GI complaints at the same time that they have the joint complaints. So that's key. So if you look for that on your boards. So spine and sacroiliac involvement usually runs independently from the GI symptoms, but from the most part, the other joints, they run along with the GI symptoms. You treat these patients, like I said earlier, with sulfasalazine. It controls the peripheral joint disease, and also you control, like if you need to control like the spondyloarthropathy component, you do TNF alpha blockers or methotrexate. So this is a more severe type of involvement. On your boards, they may want to trick you with rheumatoid arthritis, but if they give you like GI complaints, you guys know that we're dealing with the enteropathic arthropathy. And lastly, psoriatic arthritis. Typically on your boards, if they show you a DIP joint, you guys think about which two conditions? Osteoarthritis and psoriatic arthritis. So don't forget that on your boards. So that's why I put it in red. The DIP joints are commonly involved, and these patients can actually have like the nail pitting or like destruction of the nail bed. So just look for that on your question. The treatment, you treat them with NSAIDs, and sometimes for refractory cases you need to give them DMARDs. And the anti-TNF, I don't know if you guys have rotated through a dermatology clinic, like psoriasis patients, they get like this anti-TNF, they're very responsive to that. And if you have like the arthritis component, that's another clear indication to use them. Plaquenil is not used because it actually exacerbates the skin disease. So that's another key thing. So if they give you Plaquenil, please don't answer Plaquenil. We don't use Plaquenil for psoriatic arthritis. Okay? All right, let's go ahead with the next one.
A 70-year-old male dairy farmer is evaluated for a 1-year history of pain in the left knee that worsens with activity and usually progressed. On physical examination, vital signs are normal. A small effusion is present in the left knee, but there is no erythema or warmth. Range of motion of the left knee elicits pain and is slightly limited. Extension of this joint is limited to approximately 10 degrees. The flexion is nearly full. The remainder of the musculoskeletal exam is normal. The erythrocyte segmentation rate is 15 millimeters per hour. A standing radiograph of the knee is shown. Which of the following is the most likely diagnosis?
So that X-ray has classic findings of what condition? Osteoarthritis. So some of the things we do is like decrease the narrowing of the joint space and the chondrocalcinosis of the tibial plate. So typically, rheumatoid arthritis, you see erosions and the knees are not as commonly involved as other joints. And a meniscus, you don't see that on a plain film. You need to do an MRI to be able to do that. So one of the important things in your boards, and my last slide is for you guys to always make sure that you distinguish inflammatory versus non-inflammatory arthritis, because that's going to open like a whole different differential. So make sure that you know the difference. So when you're in the urgent care and you get a patient with an acute joint, you have to do an arthrocentesis. If you don't do an arthrocentesis, you're risking a malpractice case. And on your boards, you always have to do an arthrocentesis. Why? Because you're looking for things like a white count, and you're looking for needles, or you're looking for rhomboid crystals. And I have another slide that is actually very, very good describing those. But the bottom line is that if you have a patient with an acute joint, you have to do an arthrocentesis. If you don't know how to do it, call somebody who knows how to do it. You call either the orthopedic or the PA. A lot of the PAs, the ortho PAs, they do that for you. And if it's the ankle, I don't know how to tap the. I know how to type it, but I don't take the risk because the risk of like failing is pretty high if I do it, and it's pretty painful to tap the ankle. The knee is very easy to tap. I don't know if you guys ever tap a knee. His knee is extremely easy. You can either like